kind of have to play the game of which one is first. One, we say go low and slow. So that might be an X-ray, which then says, nope, we need an MRI or a CT scan. Is this medically necessary in this point of time? And it may be, but we need the proper steps to get to that end result.
Welcome to Under the Coverage.
During each episode, we interview people, sometimes it's just each other,
who spend their working days focused on health benefits and health care.
As consumers, we want the same thing you do.
We want the entire system to be less complicated.
Our guests share insights about how they navigate healthcare and the health benefit systems. I'm Jolene Myers.
And I'm Sarah Flusky.
And we're ready to lament,
complain,
empathize,
and maybe help a few people. For this episode, we wanted to dive into the definition of medical necessity. We invited Lorene and Stephanie to join us again to discuss things from a clinical perspective. Lorene holds a bachelor's and master's degree in nursing. She's worked in an oncology setting and at Nova connecting with patients and members. And she's also a volunteer with Camp Good Days. Stephanie has more than a decade of experience working in clinical and insurance industry settings. She holds a master's degree in public administration. Thank you both for joining us again.
Welcome again. So we've invited you here today again. You guys have been on a few of our episodes now. This season, Sarah and I have been focusing on building out our glossary of terms on our website with podcast episodes to help members dive a little deeper on some of the written definitions. We want to address some terms that listeners might be familiar with, and one of those is medical necessity. So often it's something, is being reviewed by the insurance company, or if it's something that's denied, you might hear that it's not medically necessary. So help us understand what that means if you hear that term. If you want to just kind of dive into a high-level overview, and we'll take it from there.
So a broad definition of medical necessity is healthcare services or supplies that are considered essential for diagnosing, treating, or preventing illnesses, injuries, or medical conditions and meet accepted standards of medical practice. The goal here is to ensure that services or supplies are truly necessary for the patient's medical condition and align with evidence-based standards of care for that condition.
When something is reviewed for medical necessity, what does that process look like?
So when something's reviewed for medical necessity, we do have at Nova internal criteria and also policies that we leverage and utilize, as well as our medical directors that review each, whether it's a surgery, a diagnostic test, an inpatient hospitalization, medical necessity. That review is done by looking at the clinical scenario of that specific member, as well as the requested service, procedure, whatever is being requested by the provider or the facility. There is an established set of criteria that's reviewed against that has been pre-established for that specific scenario. So if you are admitted to the hospital, we have a set of criteria set up for a hospitalization for whether it is a broken leg or a heart attack or things like that. There are certain criteria that has to be met so that that hospitalization could be approved. So, for example, if you have a broken wrist and you go to the hospital and they admit you, that may not be medically necessary if they could have just treated the wrist at an observation or a lower level of care and didn't need to admit you into inpatient level of care.
I think another example to help break it down that most people are familiar with would be, surgeries, certain surgeries or certain imaging. So when we think of surgeries, we have things that are needed before you go in. Most people are familiar with that you need to get clearance from your provider, but we have to back that way up and say what imaging was needed. And oftentimes that might be something like an MRI, which to get the MRI, they may want to know, did you have an X-ray first? So you kind of have to play the game of which one is first. We always start with the lowest one. We say go low and slow, right? So with the lowest one, the least invasive, so that might be an X-ray, which then says, nope, we need an MRI or a CT scan or a PET scan, depending what you're looking for. It might be instead of back surgery, well, did you have conservative care, which involved the X-ray and perhaps some physical therapy for a certain amount of time before we jump in to the invasive procedure, which is not just an expensive back surgery, but there's a lot of potential for long-term side effects, ongoing pain, and that sort of thing. So that's what we're looking at. Is this medically necessary in this point of time? And it may be, but we need the proper steps to get to that end result.
I'm so glad you brought up MRI because not only am I in my 40s now, but a lot of friends and family, you hear that term a lot. Oh, I just want to get an MRI. Why does it take so long to just get an MRI? Why can't they just scan us? So I'm glad you brought that up because, you talk about it being necessary, but also there's the cost management piece behind it. It's expensive, right?
Yeah,
so
very.
we all see premiums going up and everybody complains about healthcare, the delivery system down to the claims and all of that stuff. But I think it's important for people to understand it's not just a, quick and easy process. So there is all of those steps to take. Is there a service that could be done that's going to be less expensive, less invasive, as you mentioned? So I think that's a great example.
Yeah. Like in my clinical training, we were always said, like, don't look for the zebra, which is that far thing, the like one-off chance. So you're going to do the normal things, which are take those baby steps. For every headache, you're not going to jump to a scan of the head to see if there's a brain bleed, right? Headaches are very common. So we're not looking for that zebra out there, which is why even in my background with oncology, we know things need a PET scan. But before we get that, we're going to do some other scans first before we get to the PET scan, if we need the PET scan. Yeah, all very costly, but also, taking into what does that mean to you as the patient? If you're getting all of those rays and all that imaging done to you, there may be some other side effects of certain testing.
So if something is deemed not medically necessary, it's possible that it is deemed not medically necessary at this point in time because there is a desire to see less invasive or less intense attempts to rectify something before you move into something that will be measured as not medically necessary at this point in time. Is that right?
Yes.
Right. Yep. Because something else could have fixed it, right? If, a few weeks of physical therapy, 6 weeks of physical therapy gets rid of pain or lowers your pain to something that's manageable, then there's no need for you to get into a back surgery where there could be some lifelong complications or implications to jumping into that.
So where do you see, and I don't know if this is something that you can address broadly, but when you see something not approved because it isn't considered medically necessary, does that come from a clinical, it's a recommendation of the provider to go get X done? This is what the doctor is saying the patient needs? Or is it Sarah saying, like, forget all this nonsense. If the doctor's telling me that at the end of the day, we're probably going to end up at surgery, I'm in a lot of pain. Let's go to surgery. Do you think it's driven by the member wanting these things done, or does that come in through a provider's office?
So that determination, a surgeon or a provider may certainly say, I think you need surgery. I'll clear you for it. I'll submit to your insurance company. But if we get that request and it comes in and you've been having back pain for a month, but haven't gone to the chiropractor, you haven't had an x-ray, you haven't even been to a physical therapist, those are going to be things that within our criteria are identified as conservative measures that should be trialed first. And or if there's a reason that you can't do physical therapy, if the pain is too intense, then that's something that should be identified in the clinical documentation that your provider is sending in. So within our criteria, we have all these things that our nurses and our medical directors are looking for. If in our initial review, we find, I don't see any physical therapy notes, we'll outreach to your provider and inquire if that's been done or if they are planning on sending you for that. If it's something that is in the works or has been done, if they forgot to submit those notes, then okay, great. Now we have the notes. We know that you've tried all these conservative measures. Sometimes providers don't always know what we are looking for before they send for a surgery or a test. So sometimes there is a little back and forth of provider education piece as well, and letting them know, hey, before you go forth with this intensive inpatient back surgery procedure, trial them on some physical therapy, see if that improves any of their symptoms. Maybe they're a good contender for some sort of pain management injections instead of a surgery. Those are things that the doctors can then explore, and they'll have additional insight into other options for their members that they can then look at and pursue.
On the flip side of that, there's also that medical necessity it's a checks and balances. So it's checks and balances to put in order that we're not doing harm, right? First, do no harm, but also that the care has been put through series of studies and tests and trials. And so there's things that might sound out there, but there's also things that very well could be helpful, but it hasn't passed FDA approval yet for this condition. And that's why you might have to try something else. So it's a very broad topic and statement to talk about. And there's many components to it. And it's not just, as we've mentioned before, the big bad insurance saying, no, you can't have this. It's checks and balances. Honestly, it's a safety measure.
But this is also, it makes me think of the fraud, waste, and abuse training
Absolutely.
that we go through. So I feel like it's, when you talk about checks and balances, it's also that there are some bad actors who move towards the higher cost. You're just going to move towards the higher cost thing because the reimbursement is greater, right? That's not every physician, but there are some, and that jacks up costs for everybody. So if you ensure that those lower levels of treatment or care have been walked through, or the physician can document, here's the reason why we need to move to this extreme at this pace, it can change something to being medically necessary. So when I think about the risk of fraud or generating unnecessary bills or putting people through really intense surgeries or procedures and then recovery when it might not have been necessary, the other side of me that isn't advocating aggressively for the thing that I would like to have done because my doctor said I need to have it done, when I'm not in a position of needing it at this moment or wanting it at this moment, I can see how the checks and balances help to manage the cost of insurance as a whole, I guess.
That's exactly it. It's cost of insurance and it's cost to the members' own financial well-being, but also cost to their life, right? Because everything has equal and opposite, right? So we've talked before in other episodes about, that one bad apple can ruin some things, but the checks and balances are there to protect everyone. And then sometimes it's just needing that additional step to get there. And it's not meant to be red tape, but it is a checks and balances. So that's why, at least here, we're looking to work together to eliminate that as a barrier, but making sure that you're getting the care you need in the right setting at the right time. And that is the right care.
So what happens if you are denied, if the service that you would like is deemed medically not necessary? Can you appeal? Can a member appeal?
Absolutely. Whenever we deny any service, whether it's inpatient, outpatient, surgery, and MRI, the member and the provider will always receive a denial letter and notification, letting them know that it was denied, letting them know why it was denied. So within that letter, there's always going to be a rationale as to why it was denied. So for example, we'll stick with the back surgery scenario. So we get a request for a back surgery, and it turns out that the member hadn't had any conservative treatments or had only done a few visits of PT and hadn't gone for a few weeks of it to show any improvement. So in that denial letter, it will outline specifically the rationale as to why it was denied, and it will say something along the lines of, in order to perfect the claim, we need to see proof of conservative therapy. As a result, within the denial letter, it will outline specifically the reason that it was denied, what is needed in order to allow it to be approved. And within our denial letter packet, it includes the entire denial letter that cites that reason. It includes the appeal filing form, and it includes a tip sheet on your right to appeal, how to file it, how long you have to file it, and all of that. And of course, it has our phone number in case there's any additional questions that we could answer for you. But like I did previously mention, the provider is also notified of that as well. So whenever something's denied, we always call or fax the provider and let them know. At that time, we also offer the provider an option for what's called a peer-to-peer, which gives them 2 days for their physician to discuss the denial with our physician and see if there's any recourse there. That is only for pre-service requests. So retrospective requests are not eligible for that peer-to-peer, but there is that option as well for the providers when they are submitting something on behalf of a member. They have that recourse as well with the peer-to-peer process. And then the members certainly always have the right to appeal, and all of that denial letter and that information the member can reference. And I always encourage them to go back to their providers as well to assist them in filing that appeal, because if we're outlining, hey, we need an x-ray, we need conservative treatment, we need a letter certifying that you can't have these injections done elsewhere, the provider's going to have that information and they can help the member kind of collect all of that. Usually providers actually will submit the appeal with the member can come in, sign the form. They'll send us the whole appeal packet, and then we can get that appeal process going from there.
And if I can add on to what Stephanie mentioned, you said coordinating with their provider. I think that's the key piece, because so many times we find if there was a denial, it may have been due to what we call a lack of information, meaning not all of the criteria that's needed for that medical necessity came through, and they have to make a judgment based on those checks and balances to what was there. They may request from the provider more information, and it might not come through. And so on their end, they're hearing, well, my doctor said they sent it in. And then they get, kind of upset on our side, but it may not have come in. It may not have come in timely. But most importantly, it's just that communication among all sides, because we're all human. So I've worked in an office. We've all worked in different settings. So we're all human. It might be that the medical assistant or the nurse or whoever was sending it in forgot to add that they went to physical therapy. And it might be as simple as that. And when we think of the delay in care and how upset we all might get, when really at the end of the day, we're all human, and it might be as simple as engaging in coordination of care.
A scenario we see quite frequently is sleep studies, actually. So people might be snoring, maybe wake up super fatigued every day. The doctor says, I think you need a sleep study. So they send in a request for the member to go to a facility and have the sleep study done, stay overnight. And if there aren't additional reasons as to why the member can't have that performed at home, that can result in a medical necessity denial, because they can do at-home sleep studies. And those are far cheaper for the member to have, and a cheaper copay or co-insurance if they have a deductible, that sort of thing. So we see often that if we do deny them and say, hey, you can have a home sleep study, sometimes we never hear back from them. They end up doing the home sleep study. They find out, hey, I do have sleep apnea. I need a CPAP machine. And then they're able to get that care and start that right away. They don't always need to go to that higher level of care, that facility sleep study. They could just do that at home, and it's a cheaper cost to them.
I had no idea you could do a sleep study at home.
Absolutely. The preferred way now. And, for no one to be scared, if you've ever seen anyone with a nasal cannula to get oxygen, that's all it is. It looks like a little nasal cannula in your nose, and it's monitoring you, and you wear a little monitor that's probably the size of I'll say it, like a Walkman, right? Just it's just a little monitor that they will, have you strap on. It connects to the strap around your chest, and they'll put on, some little sticky notes. If you've ever had your heart monitor done, they'll do that. So it can monitor your breathing and your heart rate. Super simple. Yeah. And then you just drop it off the next day, and they'll read it and let you know what it is. So that is the preferred method in the comfort of your own home.
Yeah.
At the time that you normally sleep.
Right. In the bed you normally sleep in.
Yes, exactly.
Yes. Surrounded by the people that are usually around you, and not an institutional setting.
It's really a good example, Stephanie. Thanks for bringing that up, though, because so many times members will call in frustrated. And why was this denied? How is this not needed? No, it actually is medically necessary for you to have the study. So let's confirm that. It is medically necessary for you to have a sleep study. However, it is not medically necessary for you to have it in a facility. So we're not saying no. But remember, I said it's the right location, the right time, the right all this stuff, right? So it's the right setting.
Learn something new every episode.
Every episode.
Well, our goal today was to wrap our arms around a complicated and often frustrating part of the health insurance landscape. So these determinations are not going away, and we can't fix all of the problems, even though we try very hard to. I think our goal is just to help members understand the process behind all of this, and I hope that we helped them understand that today. So thank you, ladies, for sharing wonderful examples. And now I'm like, I think I'm going to get a sleep study done. But maybe it's not the right time in my life, because I have a 2-year-old and a 4-year-old and a dog, and sleep study around here might be a little challenging.
I think this is helpful, at least in, helping people to identify what questions they can ask to move forward. So I do appreciate your time.
Absolutely. Thank you for having us.
This podcast was brought to you by Nova Healthcare Administrators.
Do you have a question or a situation you'd like advice about?
You can find us on Twitter at UNDR The Coverage.
If you're into email, you can reach us at podcast@novahealthcare.com.
Don't forget to leave a review, give us a like, or subscribe, but more importantly, share.
We'll find the insiders. You share it with the outsiders.